Welcome to the third and final presentation today for the Rehab Symposium. COVID cocktails, shaking up your recipe for success. We have two outstanding presenters today, and I'm going to introduce them now. Casey Lee is with Quality Rehab Management. She's the Director of Quality Improvement and Education. Casey's a physical therapist who's dedicated her career to post-acute and long-term care. She's deeply passionate about the future of skilled nursing facilities and rehab and post-acute care, and uses this energy to facilitate quantifiable improvements in Section GG outcomes. She's a frequent presenter at national conferences and webinars. We also have with us today Jason Jones. Jason is the Chief Technology Officer at Simple LTC. Jason oversees product and technology strategy for Simple LTC, a provider of analytics and workflow software for over 4,000 facilities. He's an expert in healthcare data analytics and has presented on technology topics in numerous forums and many national conferences. So welcome to our speakers today. And Casey, I hand it over to you.
Thank you, Cynthia, and thank you so much to NASL for inviting QRM and Simple LTC to share this cocktail hour inspired session with you today. Jason and I are very excited to be your bartenders for the next hour, so we hope you'll sit back and relax, grab a cocktail or a mocktail, a bev nap to write down any of your questions. Jason and I will be available live following the session to answer any questions you have. Here's our cocktail hour menu for today. We're serving 3 clinical best practice cocktails. These are recipes for success to serve before, during, and after the public health emergency. But before we get into the cocktail recipes, let's go over a little bartending 101. A good bartender knows when to use the right ingredients mixed up using the right tools and the right mixology techniques and served up at the right time. Where would the bartender for 007 be without vodka and a proper shaker? That bartender might be able to serve a perfectly fine martini, but not 007's vodka martini shaken, not stirred. So the wrong ingredients, the wrong mixology techniques, and the wrong timing. If you're listening today, you likely serve a population with a whole lot of ingredients to work with: underlying impairments, functional deficits, comorbidities, conditions. We're going to focus on the ingredients that are specific to COVID. We're going to discuss mixology techniques and tools and trends and clinical best practice strategies that you can use to mix up those ingredients and serve the best cocktail at the right time. We're going to discuss tools that are already in your toolbox. They're tried and true. You've used these tools and techniques for a long time, but we're also going to discuss some new opportunities, including CMS flexibilities that have been gifted to us during the public health emergency. And if you're not using these gifts, these new tools in your toolbox, I hope after today's session, you'll consider it. They were gifted to us by design to protect us, protect our residents from exposure, but also to ensure that we have access, that we have the ability to focus on those essential rehab goals and interventions without a delay or interruption in service. So that's a good bartender. We got the right ingredients identified. We've got the right mixology techniques and tools to mix up those ingredients served up at the right time. But you're here today because you do something extra for your population to better serve your residents. And the extraordinary bartender who does the extra uses information from the customer to anticipate needs. It's not an accident that a resort cocktail menu looks totally different from a fine dining cocktail menu. That is due to customer information. Those bartenders anticipate the needs of their customers at different times and different locations. We're going to do the extra today. We're going to review customer information over a 13-month period, and we're going to use that information to help us determine what cocktail recipe to apply at what time based on our customer information that they've given us. This is the same information that CMS is looking at right now because it's coming from the MDS, specifically Section GG. We're going to compare what happens at discharge, the discharge performance assessments in Section GG. We're going to compare that to the expected performance targets. And Simple LTC has created a report, the function scores report, that's going to help us calculate our performance at discharge compared to the expected targets. And I'm going to pass to Jason with Simple LTC so he can explain the function scores report.
Yes, thank you so much, Casey. So as Casey's going to go through and give a lot of the real meat of this, I should say the real ingredients of this cocktail. I'll put meat in that, right? But it's always nice to know the source data, kind of the background of that. So if you're not familiar with Simple, we basically, what we did is we took anonymized data and the calculations from the QRP manual. And this data came from MDSs that we transmit to CMS. We do that for about 24% of the United States. So it gives us a large sample group. So the sample group for this study came from about 3,200 SNFs facilities throughout the US. One note on that, it's not truly random for all the stats professors out there. I want to keep you happy. This is a sample group of our customers who tend to be a little bit on the larger side, larger companies, larger management companies, although we do have many standalone single facility operators. But we do have, the data is a little bit skewed to the larger companies, and also the states of Texas, California, Florida. We have a lot of data from those states, although we do have data from 49 states. The only state that is not present is North Dakota. So it's a good sample group. It's very useful data. And then what we do is we calculate episodes across a time period. So in this case, we looked at 352,000 episodes calculated over a 13-month period from August 2019 to August 2020 using the QRP dated as of, I believe, 3.0, which was October 1 of 2019. And if you look at the next slide, we can tell you kind of where how it's calculated. It's a 100-page document. It's produced by RTI and for CMS. So I won't, we would have to have a very long session if we want to get into that. So we won't get into that. But I will tell you that the data comes from section GG of the MDS, which you're probably very familiar with if you're watching this. The 5-day assessment sets your baseline admission performance and expected discharge scores. And then the PPS discharge will set the actual discharge score. So the expected discharge score is calculated from 62 covariates gathered in the 5-day assessment. So it's not a simple calculation. There's a lot that goes into it, a lot of exclusions and whatnot. But once you have that, it's kind of like a crystal ball into what's expected and what CMS is going to look at. Sometimes it's easier to talk in terms of examples. So for example, a resident who used a walker prior to admission will have a lower expected mobility improvement than one who did not use a walker. So if you miss that item on your 5-day, it would inflate the expected discharge score in the CMS algorithm, which is not something you want. You're kind of setting yourself up for failure in those scenarios. So that's kind of an idea of where the data came from. The section GG function score report, this is just a little screenshot from Simple Analyzer. It's a product that we make. But it basically, you can look at it by resident or by facilities, but this gives you kind of an idea of what Casey will be alluding to during your presentation, kind of where the data comes from, where we can look at the mobility benchmark and the self-care benchmarks, and also look at that kind of your grouping of your residents as compared to those benchmarks. What Casey's going to be doing today is going to be a much larger sample group, like I said, over a much, not just one facility, but 3,200 facilities. So that's where the data comes from. That's the information that we've pulled together. So Casey, I'll give it back to you and you can tell us the wonderful things you can do with this information, right?
Absolutely. Thank you so much, Jason. So the function scores report that Jason and his team at Simple created, that's what we use to calculate the expected performance outcomes that are reflected on this graph that we're looking at right now. So that top line, the purple line all the way across, that represents our discharge performance for the mobility items compared to the expected performance scores from the function scores report. And the blue line right underneath is the self-care expected performance outcomes compared to, so what happened at discharge compared to what was supposed to happen, that expected score from the Simple LTC function scores report calculation. And so if we're gonna talk about the drop, right? There's a big drop in March, just can't not see that. But let's kind of look and appreciate at what was going on before the drop, before March, and zoom in to August of 2019 through February of 2020. You got two lines kind of straight-ish, close together above the 75% mark. So our trend prior to COVID was we achieved the expected performance outcomes about 75% of the time or greater for the mobility item set and the self-care item set. And then, of course, we took a pretty significant dramatic turn in March with the introduction of COVID into this data set. So the U07.1 diagnosis, COVID-19, is not available in the data prior to March of 2020. So with the introduction of this new diagnosis, you can see our customers are telling us their outcomes have declined dramatically, but I hope you also see that we took that drop in March. It was, we were all caught off guard, right? And then we're figuring it out. So the rebound has also been swift and rapid. We are not back to our pre-COVID outcomes. If you scan all the way over to August of 2020, you can see those two lines are now getting close together, approaching that 75% benchmark, but we're not there yet. We haven't crossed it, but we're going to continue to learn and apply lessons learned to better serve this population. The two highlighted lines below the mobility and self-care expected performance outcomes, that represents patients with a U07.1 diagnosis. And you can clearly see these patients have outcomes below the rest of the group in this data sample. All right, so what we're going to do is we're actually going to take out a magnifying glass and zoom in to different sections of this graph and see if we can appreciate any additional details, information from our customers to help us anticipate needs and apply the right recipe for success. So we're going to take our magnifying glass out and we're going to hover over the time period before COVID, August 2019 through February 2020. And when we zoom in, it doesn't look so much like a just straight line anymore. We have some detail to appreciate more here. And the biggest detail I see is we're trending up. The outcomes are improving and the timeline is right in line with the introduction of a new payment model, PDPM. If you take a look at our mobility outcomes, so the purple line on the top, in August and September, pretty stable, right above that 77% marker, and then boom, big increase in October, big increase in November. We took a dip in self-care and mobility in December. That could be a reflection of the holidays, but in January and February, we're back on track, trending up. This is a recipe for success. This is a recipe for success to be served before the public health emergency. Clearly, that's what this data represents. But I want us to discuss some of the mixology techniques that we used here because this is working. And some of the techniques that we used prior to COVID, we can use right now during COVID. But there's a couple things that we're not able to do right now. Just it does not work with the diagnosis with reducing exposure risk. So we're going to hang on to this recipe card because this is a recipe for success. And the purpose of PDPM was to improve outcomes. We knew that from the beginning. We're going to focus on patient-centered ingredients, patient-driven ingredients to drive improved quality outcomes and improve our value of service delivery. So let's take a look at the recipe card for the conventional cocktail, the old-fashioned, if you will, best served after the public health emergency. Some of these mixology techniques are not going to work right now, but we're going to hang on to this recipe card for a future date. But if you take a look at the right side, our mixology strategies here, PDPM is part of our mixology. It's part of the science of what works here because the model of care is individualized and tailored to the patient. If you look at your ingredients, the patient provided all of our ingredients under PDPM. Active diagnoses, conditions, comorbidities, presence of cognitive impairment, swallowing disorders, the patient drove our interventions. And clearly, if you look at the outcomes, it was working. We were seeing a positive impact of the new model. It encourages interdisciplinary collaboration, a focus on quality outcomes versus quantity of services, volume of services delivered. It encouraged us to individualize our therapy plans. There's no more magic number of minutes that's going to get our outcomes on track. And when we made this shift and started individualizing our therapy services 5, 6, 7 days a week, 2, 3 days a week, whatever is the right recipe, whatever is the right combination, we can see in the outcomes that it was working. It was moving us in the right direction. I have italicized a couple things that maybe don't work in the COVID cocktail world. Group and concurrent. We did see an uptick of group and concurrent provision of care. And again, I go back to, let's not lose sight of that. Let's keep that recipe card handy because it was working. Our outcomes were improving, but it's a challenge now in our current climate to do the group and concurrent services. I'm not saying that we can't do it. We're going to talk about that later, but it does present challenges. Our healthcare resources, the way that we use staffing and resources, I have that italicized too, because in a conventional cocktail, it worked just fine to have one evaluating clinician who supports multiple facilities, multiple assistants, hundreds of patients sometimes. It works when we're not in a pandemic. And so that staffing model is probably not going to work, and that's going to be something we're going to hold off, put in our recipe card box, and bring it out at a later time when it's safe to do that. Our providers were able to move around. Well, we really can't do that. That increases our footprint. We know that that increases exposure risk. And all of our services were being provided in person, hands-on, because really up until the pandemic, we didn't have any other options. We were not authorized providers of telehealth. We weren't doing remote visits. It just wasn't a thing for us up until the March, April, May of this year. But the garnish, the cherry on top, we were approaching 80% outcomes. We were achieving, getting close to achieving, and the mobility outcomes actually did achieve and exceed the 80% threshold. So 80% of the time we were meeting those expected performance targets based on the Simple LTC function scores report. And guys, I think that's where we should be living. I don't think 100% is the right number. I think that's unrealistic. We've got patients that are not going to achieve those expected targets. I think Jason's example is great. If we're not coding some of those things right, we're going to have an inflated number anyway. And so we have to get our scores as accurate as possible, but I don't think 100% is the right number. I think somewhere between 80 to 85 is where we should be living, and we were getting there under a conventional cocktail recipe. But the challenges, a conventional model does not account for a reduction in workforce. Once we started seeing surges in COVID in areas, our staff was getting exposed. So then they have to quarantine, and a conventional model really doesn't have an answer for that. The reduction of force due to reduced PRN. In a lot of cases, we were being mandated to not use PRN. Again, we don't want to have people floating around that have been to other facilities, possibly picking up and then spreading COVID in our facilities. That limited our access to evaluators. So during that initial drop that we're going to talk about, we're going to take a closer look at it. During that rapid decline, we had limited access to evaluators. We were not moving therapists around. We were really struggling with our conventional model. And other things that our conventional model really doesn't address is it doesn't support the American Healthcare Association and the National Centers for Assisted Living guidance. They gave us guidance in the very beginning to rehab professionals, PT, OT, and speech, to limit movement, because movement between facilities was a known increased risk of exposure. So they charged us with not doing that. And we stopped because that was, at that time, we didn't know, we didn't have a lot of information. We didn't have historical data on COVID yet. And so we did what the guidance suggested. And so we stopped, we limited movement to reduce spread and to reduce risk of unnecessary use of PPE. At that time, when this guidance came out in March, PPE was a hot topic. It still continues to be. But whatever we could do to reduce the use of resources and limit touch points with our patients, that's what we were asked to do, and that's what we did. They also gave us guidance to discontinue group and concurrent. We had done all of this work under PDPM to increase our use of group, which we saw, again, the outcomes were improving. It was a positive, it positively impacted our outcomes. But then we were guided to stop. And we did, because again, we had to at that point. But there are results, there are negative results that are impacted by the forced lockdown, the inactivity, the social isolation. Like, there's so many negative impacts. Some are immediate. I think that's what we're going to see in March, is that immediate drop in outcomes related to lockdown, related to reduced access to therapy, to the confusion. Guidance was unclear about telehealth for institutional providers. There's just a lot of uncertainty. And you see that immediate drop in outcomes that we're going to appreciate here in a second. But there's some long-term effects as well that we're going to discuss that are related to social isolation and inactivity. And we need to have an answer for that. And hopefully one of these cocktails will help you with those answers. Okay, so we're taking our magnifying glass and we're looking at the drop. I don't think we really need a magnifying glass to look at this drop, because here it is. And you can see, so if you look at the purple line, the top line, mobility outcomes were in February, had just crossed the line that I think where we should be. 80%, 80 to 85% of expected performance outcomes, we should be there. And so we got there, and then we dropped down 20%, below 60. So a huge impact on our customers are telling us that their outcome performance dropped significantly. But this is also related to no preparation, no planning. If you think back on the slides, the PDPM slides, that positive trend, we had a ton of time to prepare for that. We had no prep for this. It happened. We had, again, uncertain guidance on, can we do telehealth? Can we not? Is it for Part B outpatient? Is it for institutional? Is it for Part A? And we knew we need to decrease touch points. We had staff that were getting exposed. There's just a lot happening with these March discharges, and that's reflected here. But to me, the silver lining, the beautiful thing is, look how quick we turned it around. We immediately started applying lessons learned to improve the outcomes of our patients. We're not going to stay down in this hole. We're going to dig ourselves out, and we're going to do that by applying knowledge from our data from our patients, using our customer information to anticipate, but also lessons learned. So this is a sour cocktail. We hope to not serve this again. A whiskey sour is perfectly fine, but we do not want this to happen again. We don't want to get caught off guard without a plan. So if you look at our mixology, question mark, was there a science to this? Not really, because we didn't have a historical framework to work with at this point. We went to a forced lockdown. We went to inactivity and isolation because that was the safest thing to do at that point with the lack of information that we had. That reduced services. Rehab went down, outcomes went down. It goes hand in hand, no matter what. We had a delayed response time to deal with new problems because we couldn't get evaluators in to address those problems. Our healthcare resources at this point were just stretched to the limit. We had staffing issues, the PPE issues, medical equipment, cleaning supplies. It was just, we were stretched beyond our limits. And that kind of creates a vicious cycle too, because now when all of our resources are depleting, then our exposure risks go up. So we were surging at the same time. We were getting more cases. And the ingredient that we're working with here, it's novel, it's new, and come to find out, it impacts every patient differently. It attacks or impacts multiple systems depending on the patient's pre-COVID status. And the illnesses range from mild to no symptoms to life-threatening. That we were dealing with the spectrum that was just incredibly challenging. And so many systems impacted: pulmonary, cardiovascular, neurologic systems, musculoskeletal, you name it, it was impacted. So again, we were caught off guard, but we're fast learners, the garnish, the cherry on top. Our outcomes did rebound quickly. But here's what happened and what we want to create cocktail recipes for in the future to address and ensure we don't end up with the sour cocktail recipe again. We don't serve this recipe again. And the impact of physical inactivity and isolation, I think we saw that as an initial hit, but we're going to see it again later in a few other cocktail recipe slides. But I think first and foremost, we had limited patient access to therapy. You got to have therapy. And we were in a tough position because our conventional model, it can't apply to this new world. So we were having a hard time figuring out how to manage this new population, new challenges, new mandates. And then that unclear preliminary guidance on telehealth. The telehealth guidance came out, initially in March, maybe early April, but it wasn't clearly describing institutional providers. So long-term care, skilled nursing facilities. We were kind of left out, and that unclear guidance was just really challenging for us to make an impact and get in front of our patients to give them the services that they needed. And so that led to dramatic declines in expected performance outcomes. So that graph, you have the result. Your customers have given you the story. Outcomes went down when they didn't have the access. And you're going to see that initially in March with that first drop. And then we see it again a little bit later in July. And the adverse effects of social isolation and physical inactivity. I mean, here's just a snapshot of all of the things that are impacted by isolation and inactivity. There's medical effects, decreased cardiovascular function, sleep quality goes down, medications go up, which increases fall risk, exacerbation of all sorts of other medical conditions, including dementia, pressure ulcers, respiratory issues, weakness, the list goes on and on. If we don't address this problem, and I know that there's a lot of literature coming out about this because the outcomes are clear. If we don't have an answer for this, our outcomes will continue to go down. We might see a slight improvement, but they will not get back to the level that they were before. And then other social isolation adverse effects, weakened immune system, fear, anxiety, depressions, accelerated cognitive decline, concentration problems, memory problems, increased negative behaviors. It's devastating, we know, and it's also clear in the data. So that's the sour cocktail. We're not going to serve that one. That one, you can take the recipe card and just toss it. Just important to note, this is the slide I love. I love what we did when we started applying lessons learned immediately, and we did it fast. So April, May, June, we took that sour cocktail and we turned it around. We served up your next recipe for success, the crisis cocktail. Best to be served during a surge when you're seeing a lot of additional cases. You have a community in surge, you have a facility in surge, high number of cases, high number of exposure. And during April, May, and June, we were seeing surges in the U07.1 diagnosis in the episodes reflected in the data. So I think this is just a great representation of what we do when presented with a challenge, and you just give us a little bit of information and we turn it around. So it's fantastic. So mixology, if we take a look at the right-hand side, the things that are specific to a surge period, you're in a hot zone. You got to have that dedicated COVID team. You got a cohort, you got to have a COVID team that does not treat your non-COVID, your COVID team that treats your COVID patients and does not treat your other population. You have to have a separate team, and you're not crossing either. Like, you're really kind of one-way traffic into the COVID unit, one-way traffic into the non. You do not want to increase exposures. The goal here is to reduce exposures and get people back into a more interactive routine, more engaging routine. But you can't do that until you calm down the fire. Like, you got to bring the surge down. So in a dedicated COVID team, we're going to have expanded roles. We cannot limit our scope of practice when you're in a COVID team, because I don't want a ton of people coming in. I need a specific number of people, and those specific number of people need to handle all of the care within their scope of practice. So this is not the time to limit. This is the time for us to be very expansive and focus on the essential goals. What matters right now for this patient? And utilizing functional maintenance programs, which I'm going to talk about in the next slide. This is actually one of those new flexibilities that I hope you'll consider after today's session. In-room treatments, we're going to double down on those in-room treatments because that's where we're living. We're living in the room. And there's only so much you can do in the room before it becomes pretty boring and not interesting. And, you know, we need to engage these folks as best as possible. So individualize, try to get out of the bed, try to integrate sensory integration activities. I've included in the reference slide a resource from an activities professionals website, 101 Ideas for In-Room Activities. I think it's a fantastic resource. It includes all of the senses, a great way to assist with our in-room interventions and keep them from feeling stale. Monitor vitals throughout. So if you go over to the ingredient slide, one of the things that we learned about the acute COVID patients is, this is your acute presentation. These are weak people. They're deconditioned, shortness of breath, hypoxia. And some of the work group papers that I read and included in the references, lots of clinicians reporting asymptomatic hypoxia. That can have major long-term effects. So we need to be measuring vitals consistently. And I don't feel we should be pushing people too hard. Really use like a nice Borg scale, keep it at a modified level. This is not the time to be dosing for massive strengthening programs. This is the time to keep people from reverting back and declining and keeping them engaged. So focus on the impairments that are associated with that acute presentation. So hypotension, reduced ejection fraction, again, they're just weak. They just need to be getting up and moving, get them out of bed and engaged. Focus on the functional impairments, weakness, muscle atrophy, decreased exercise capacity, all of the effects of immobility. They were in the acute hospital and prone position, ventilated, probably lots of joint stiffness, possibly skin breakdown related to those positioning issues. We also see some incontinence problems associated with the acute presentation as well. Dysphagia, sometimes cognitive impairments, communication deficits, anxiety and depression, all ingredients that would be specific to that acute presentation. And we can apply all of the tools in our toolbox to address those things. These are very familiar for us to address. What might not be familiar for all of us is the telehealth services. So finally, in June, the FAQ from CMS clearly added institutional providers, us, to the mix for telehealth. And so that applies to all institutional settings. And then they further clarified, and actually this was an NASL statement that they released. I got this information from NASL, that they asked the specific questions about Part A, like, does this apply to Part A? It does. So we have that clarification. And if this is not a tool that you're using, I hope you consider it because it's scheduled to end. There's an expiration date with this. I hope that that doesn't happen, but it is there for a reason. And so we want to use every gift, every tool that we possibly have to address the outcomes of our patients because we see the negative effects. The cherry on top here, the garnish, when you're in a surge, when you're in a crisis cocktail, that's a great time to just revisit all of your infection control policies and re-educate your team on PPE, appropriate donning and doffing, reuse, if appropriate, of PPE, the correct way to reuse it. Just making sure it's just a good time to re-educate, good touch point time, because we want to reduce additional exposure so you can get out of the crisis cocktail and into the next phase. But so good bartenders mix up the right tool, right ingredients, using the right tool. So the additional tools, some of those new flexibilities that have been gifted to us include a little bit of flexibility with the functional maintenance program. So we've always had the functional maintenance program. It's just very specific guidelines. So in the Medicare Benefit Policy Manual, there's a whole section on maintenance programs, what they are, how to design them, what is a skilled delivery of a maintenance program. And one of the key items in that section is that it has to be an evaluating clinician. The evaluating clinician who creates the program is the one that has to execute the program or deliver the program if it's a skilled maintenance program. Well, that's going to be challenging under our COVID cocktail or crisis cocktail because we're trying to keep people out. Like we want a specific dedicated team. And what if that's not the evaluator? And so one of the flexibilities that's been given in a recent FAQ is that the public health emergency has allowed PTs and OTs who have established the maintenance program to delegate those programs to their assistants. And so that is something that you can use to slow and prevent deterioration until there's an appropriate time to revisit and add more restorative goals, improvement-based goals, okay? And then telehealth. I just shared, it is a new tool in our toolbox. It does have an expiration date so far. I have personal experience with this. I was so pleasantly surprised with the way that my telehealth evaluations went. I got everything I needed. And it was actually a great opportunity for me to, in real time, collaborate with my assistant. We just don't have that opportunity in a conventional model, right? Because my PTA is treating her patients and I'm treating my patients. There's never a time where we can co-treat, co-work together with a patient at the very beginning. And we were able to do that because my PTA was my therapy extender with the laptop, able to position it and put it in front of the patient and able to angle it so I could see joints. And if we were measuring joint range of motion restrictions, we were able to do that in real time together. So that was a nice communication, collaborative moment that we don't have under a conventional model. But telehealth, to be telehealth, has to be synchronous, has to be two-way, real-time, interactive, audiovisual communication. So, so you want to set up your systems now and practice with them and just get it set up to make sure it's effective. The waiver will be in effect until the end of the public health emergency, possibly later. Advocate for it. I think it's great. I'll be advocating. And here are just some common codes that are included in the list. Now, CMS is continuously updating this list. So the list that I pulled was last updated October 14th. But you can go to the website and you can pull that list and you can see there's speech codes, there's PTOT codes. The codes that are interesting to me, and I haven't figured this out yet, I mean, it's another session down the road. The codes that I'm trying to wrap my head on how I would do this. Group is in here. So 97150 for PTOT and 92508 for speech. Those are group codes. And I'm trying to think, because so right now with QRM, we're in the process of creating a virtual library of content to be able to use and share with patients, education resources. And I'm kind of thinking, could group be like a broadcast or something? So anyway, that's a stay tuned moment that I think could be in the future under this virtual umbrella. So that's our crisis cocktail. And we're going to move into our next cocktail. And what we're doing here, we're zooming out. We're taking our magnifying glass. So we just appreciated April, May, and June. We took lessons learned, what we've learned about COVID, we applied them quickly, and we started moving out of the hole that we had dropped into in March when we didn't know anything. But here's the thing. We were in the experience of locking down, social isolation. We're still not we're not doing any types of groups. And so July, we took a downward turn. And our surging, I mean, it's about the same. Like I have a slide that represents how we're growing with our COVID diagnoses across the episodes. So yes, every single month we've got more COVID cases in the mix, but we're also learning more every single month too. So the decline is a result of that inactivity and that isolation. And that's why so many people are talking about this now, because it is very clear in the data that our customers are telling us, we cannot be in this room anymore. We have to get out. And we have to have an option, a contingency plan, a contingency cocktail to be able to address that and move us up and above that 75% threshold that we saw before COVID, and really to where I would love to be, which is 80 to 85% moving forward. So we're moving into our contingency cocktail. It's our last recipe for success. It's best served after a surge. So this is not the cocktail to serve when you're hot, your community around you is hot, you've got therapists out quarantining. No, this is best served when you've calmed down. We put the fire out and we're in that next phase. What we don't want to do in this phase is keep people in lockdown, because then that all of the other physical effects, intellect, cognitive effects of inactivity and social isolation, we're going to see that reflected in our outcomes. So our ingredients here, this is from one of the work group studies specifically on the post-COVID symptoms and order of prevalence. And so they just listed them out, the most common symptoms that they found in this particular paper. Fatigue was number one. These patients are real weak and they don't really, they're just very deconditioned. So we just want to gradually increase dosage and start improving their function, getting them naturally moving in different spaces, right? Out of their room as safely as possible. Breathlessness was another very common symptom. And in the acute phase, respiratory muscle weakness was one of the impairments that was listed. I would start in the acute phase. So start when you're in crisis, stretching respiratory muscles, strengthening respiratory muscles, educating on posture awareness, diaphragmatic breathing, and I would continue this into your contingency cocktail recipe as well. PTSD, anxiety, depression, people are stuck in their rooms. They do not feel good. So what can we do to address those symptoms? Getting people together and focusing on some of those social activities as safe as possible. Concentration problems, pain, voice changes, cough, memory problems, continence problems, and dysphagia. So that was the list in order of prevalence that we can focus on. Again, that list is very familiar to us. We have lots of tools in our toolbox to specifically address those things, and which is what we're going to want to do to prevent those outcomes from declining further. On the mixology side, our science of mixing it up, virtual programs. You just set up some great telehealth platforms, virtual platforms, would not get rid of that just because you're in the next phase. I would create a hybrid of programming, a hybrid model of care where some of your visits are delivered remote. You can encourage scheduled virtual visits with family members. And then that way you can provide patient and caregiver education simultaneously. Use video clips. There's YouTube channels out there. There's lots of exercise videos. Like I said, QRM, we're in the process of creating a content library. Use all the resources you have, and that will just enhance the experience and help us drive those outcomes. Rethink and reorganize your spaces. So whatever every facility footprint is different. Every gym is set up differently, and really take a look around and think about how to get traffic one way in, one way out. Where can you put signage as a reminder on social distancing, wearing masks? Can you set up sanitation stations? At the gym, if you have a rehab gym, can you set up a hand sanitizing station right there at the door so everyone gels their hands in and gels their hands out? Can you set up designated treatment zones? So PT, your zone is over there. OT, you're over here. Speech, you're over here. And tape it off. You can tape off markers for social distancing. You can think about space outside of the gym. It does not have to be inside the gym. And I would encourage, if we can get outside, if the weather is nice, let's go outside. It's just a great opportunity to use all of the space within your facilities. Delivery of care strategies, continuity of care. It's always a best practice. Continuity of care, always a best practice, but it's kind of challenging in the conventional model because, we move people around so much and we're constantly changing schedules. And I'm sure many of you have experienced this. We try, of course, to keep the same patients on the same clinician schedules, but it becomes a challenge. Let's really try now. Let's really try to keep it contained and keep one clinician with the same group of patients when possible, if we can, to reduce touch points. Adjusting therapy plans. Your contingency cocktail should look different than your crisis cocktail, right? I mean, we're now trying to get people active in their environments and opening up that environment. So it's time to really revisit those goals, and probably time to maybe, if you were on a functional maintenance program, thinking about more of a restorative improvement program at this point. Introduce safe, socially distanced groups. So all of that information that's come out, and we've received some flexibility on bringing people back together because the impact of social distancing, lockdown, isolation is clear. If we don't get people out and have a plan, they will not get better. And the outcomes will just go right back down to where they were. And so introducing safe groups, this is a great time to discuss COVID, discuss infection control, print out all of those great resources from the CDC, and have every patient in your group with an individual copy that they're going to take with them, and have an open discussion, 6 feet apart, everybody wears masks, keep it safe, but engaging. We're bringing people back together. So extraordinary bartenders, we anticipate needs. We use that information. We saw that dip in July after all of that progress we had made when we figured out what to do in a crisis, but we saw a dip. And that dip is related to, the fact that we have that lockdown, have that inactivity, but we have a way to address it. And a contingency cocktail also we're planning for the next crisis. Like I envision that we're going to be kind of flexing between a contingency cocktail and a crisis cocktail at any given time, depending on your facility or community. If it's surging, then you might have to flip back to a crisis cocktail, but you need to have a plan and forecast your crisis needs. Set up your PPE plans, set up your staffing plans. Who is going to be your telehealth evaluator? Set it up now so you already have those systems in place. Educate and communicate ahead of a crisis. Train up on role expansions. So when you're doing your weekly therapy meetings, make sure everyone on the team knows what everybody else is working on. Just in case you have to flip and switch to a crisis model, crisis cocktail, you'll be ready. Everyone knows what everybody's working on for those potential role expansions in a crisis. Designate a COVID communication coordinator, a 3C. So this guidance was a strategy in the FEMA, it's in your references, the FEMA healthcare work group contingency and strategy paper. And I thought it was just a really good idea to have one person in charge of your COVID communication. So they're not the person responsible for the actual communication, but they're the person responsible for creating the messaging on visitor policies, on hand sanitizing techniques, on your traffic patterns in your building. They're the ones responsible for getting it contained in a one place, educating the team, everybody on the interdisciplinary team on the messaging so that anyone who comes into your building and wants to know what the traffic pattern is, everybody knows what it is because one person was in control of the creation of that content. So I thought that was a good idea because you don't want 5 different messages in a crisis. You want one consistent message. So you have one gatekeeper of the creation and the education of that information. This is a great time to make sure you've got great infection control and prevention protocols and that everybody knows what they are. You're not in a crisis anymore. Let's not get back there, right? So have those protocols in place and educate. But really important that we use the CDC's guidance on discontinuing isolation. We cannot keep people in lockdown because keeping people in lockdown will have all of those negative effects we've talked about. So use the strategies that they've given us. There's a test-based strategy. There's a symptom-based strategy. We want to use those thoughtfully as a team to slowly progress out of that crisis cocktail, that lockdown COVID unit, isolation, reducing exposure cocktail mix to your contingency model where we start safely bringing people back together and using more of the space available within your facilities. And so this last slide, so those are your 3 cocktails. So your 3 recipes for success today are your conventional cocktail. That was before it was working, PDPM, we saw really great outcomes, and we will see this model again after the public health emergency. Your crisis cocktail, this is what you do when you're in a surge. You've got your dedicated team, you're using remote visits, telehealth, and functional maintenance programs to address those COVID-specific ingredients. And then your contingency cocktail, this is your plan. We got to get people out of the room safely. We got to get them re-engaged. We got to get them physically and intellectually active, socially engaged to reduce that negative effect of the outcomes that we saw happening in July. We want to continue to move up because we should be, again, I would love to see us 80 to 85% overall. But here's an overview of the episodes within this, this data sample. So you can see August of 19, all the way through kind of March, are episodes, the total number of episodes represented in the data, hovering well above the 25,000 episodes mark for each month. And no COVID. Well, March we did have COVID, but it was a negligible amount. You can barely see it, but it's there. We had a couple cases of COVID in the March sample. But you can see, so that light blue bar in April, May, June, July, and August of 20. That represents the number of increased COVID diagnoses in the episode data. So this is not going away. And I anticipate if we look at this same graph, if we met again next year, that the blue is probably going to start taking over. It's the light blue on the top, the COVID cases episodes. So having our contingency plan, having our ability to shift between a crisis and a surge time and a non-surge time is really, really important for us to consider. And that bottom graphic is just, I think it's interesting that as our episodes decrease, so we did see a decrease in the data sample of the number of episodes included, but the blue line is our length of stay. So as our episodes went down, our length of stay went up. So I just thought that was interesting, and I thought I'd share that with you guys as a trend for this sample. I've included our references for today. I highlighted a couple of them, but all of this information is great information, but just keep looking because it changes every day. There's something new out every day, a new working group that's put together a wonderful resource for us to use and apply into practice. Here are the cocktail recipes from the slides. Now, if any of these could be made into a mocktail, but I've actually made the pomegranate mojito without the rum, and it's delightful. You just add additional pomegranate juice. It is lovely, served over ice, very refreshing. But we hope you enjoy those recipes. And before we close out, Jason and I just wanted to give a toast to your health in alignment with our cocktail hour inspired session today. I drink to your health when I'm with friends. I drink to your health when I'm alone, and I cheers to you so my intentions are known. Cheers. And we've got our Q&A slide.
Thank you very much, Casey and Jason, for that outstanding presentation. Our live Q&A with Casey and Jason is going to begin now. To join us, click the blue button above, and that'll send you over to the Zoom room where we can have a live Q&A for a couple of minutes. After that live Q&A finishes, you will need to actively go back to the session lobby to select another presentation, of which we have a couple that are on demand. Again, I want to thank our presenters, and I hope you have a great rest of your day.